Welcome dear students, I am Dr. Pratyusha and in this video let us learn about Meniere's disease. Meniere's disease is also called as Endolymphatic Hydrops. Meniere's is a disease of the inner ear, the endolymphatic system of the inner ear, and hence it's also called as Endolymphatic Hydrops. So the basic pathology of Meniere's disease is that there is distension of the endolymphatic system. Now I will quickly and briefly revise the anatomy of inner ear for you so that the orientation of Meniere's disease becomes better and easier. Okay. So in the anatomy of inner ear, we have studied that there is the bony labyrinth and also the endolymphatic system. The endolymphatic system consists of the scala media or the cochlear duct and also two bags called as saccule and utricle, the three semicircular ducts and one endolymphatic duct that terminally dilates as an endolymphatic sac. These are all the constituents of the endolymphatic system or the membranous labyrinth. And one important feature is they are all filled up with endolymph. Endolymph is similar to the intracellular fluid in its constitution. And outside the membranous labyrinth, in the space between the bony labyrinth and membranous labyrinth, we have the perilymph. In the scala vestibuli and scala tympani, the perilymph is flowing and perilymph is similar to extracellular fluid in composition. So the disease, Meniere's disease, is concerned with the endolymphatic system and there is dilatation and distension of this entire system. Let us understand the basic pathology and what is going wrong exactly and where in Meniere's disease. Now, you know about the circulation of endolymph. It is produced by the stria vascularis. In the scala media, the cross-section of scala media, you can see there is stria vascularis on one side, Reisner's membrane on the other side and basilar membrane at the base. The stria vascularis is involved in production of endolymph. And this endolymph flows through the entire scala media, saccule, utricle, endolymphatic duct and sac, and finally there are two theories. Either it gets absorbed in the endolymphatic sac according to the longitudinal theory, and according to the radial theory, it gets absorbed also at the stria vascularis itself. And according to this theory, the endolymphatic sac is just a vestigial structure because the stria vascularis is doing the job of both production and absorption of endolymph fluid. So there are two theories. But let us more so go with the longitudinal theory which says that the stria vascularis produces endolymph and the endolymphatic sac reabsorbs endolymph for our understanding. Okay. So this is the normal process of production and absorption of endolymph. Now the endolymph is becoming more in quantity and it is distending the entire system. Why does this happen? Let us see. So the basic definition you also know, it's a disorder of the inner ear. There is distension of endolymphatic system. And you know what all comprise the endolymphatic system? Yes? Okay. And the basic pathology is there is a distension of the endolymphatic system mainly affecting the main structures that are affected are the cochlear duct. Cochlear duct is also called as scala media, saccule. We know saccule is a sac that lies opposite to the stapes foot plate. Just like the utricle, there is another sac called as the saccule. It's a spherical recess. It's present in a spherical recess. So the cochlear duct and saccule are mainly affected and also to some extent the utricle, and the semicircular ducts are also affected. Now, the dilatation of the cochlear duct is the first thing that happens, and it is also the most important thing, because above the cochlear duct and below the cochlear duct we have two important structures, the scala vestibuli and the scala tympani. Now, when this bulges, it is encroaching into those two areas, and it encroaches mainly into the scala vestibuli. Because the basilar membrane doesn't give in so easily, but the Reisner's membrane is a small thin membrane, and it gives in to the pressure of the scala media or the cochlear duct, and it bulges. That is what is basically happening in Meniere's disease. I hope you have got an outline about what we are about to study. Because Meniere's disease is not as simple as otitis externa or otitis media, where the name itself gives you a hint of the disease. It's an isolated specialized form that needs to be understood specifically. So I hope you have got an idea of what's happening in Meniere's disease. Let us study about it in detail. First, let us look into the etiology of Meniere's disease. The etiology is unclear. There is no specific reason that has been found out. Nevertheless, we have various theories that are trying to explain why Meniere's disease is occurring. So, even before we understand the theories, now there are two things that can happen. When there is excess of endolymphatic fluid, it means that either there is increased production or there is decreased absorption, or both of them could be happening simultaneously. Increased production, decreased absorption, or both of them. This will result in excess of the endolymphatic fluid. So the first theory states about defective absorption by the endolymphatic sac. Defective absorption by endolymphatic sac. We have learned that the endolymphatic sac is involved in the final absorption of the endolymph produced by stria vascularis, and something is happening there. There is a defect in that absorption, and so all the endolymph that is being produced is getting accumulated in the system and causing its distension. Now, how do we prove this, or what gave us the idea that this could be the cause? Because experimentally, if we obstruct the endolymphatic sac, we could produce Meniere's disease. We could produce distension of the endolymphatic sac. And that's how it was understood that defective absorption by endolymphatic sac could be a reason. And second, in cases of Meniere's disease, while they were undergoing endolymphatic surgery, it was observed that the sac was usually ischemic, indicating that there is no vascularity, and when it is not functioning properly, there is poor absorption of the fluid, and that is responsible for this entire pathophysiology. Now, as I have earlier told you, the sac, the cochlear duct keeps on expanding, keeps on distending, and finally it leads to rupture of Reisner's membrane. And when the Reisner's membrane ruptures, what happens is the endolymph and the perilymph get mixed with each other, and this is the cause of vertigo that is usually observed in Meniere's disease. So this is about the defective absorption by endolymphatic sac. Now let us look into the second possible etiology, that is the vasomotor disturbance theory. According to this theory, there is sympathetic overactivity, and this ischemia of the internal auditory artery results in damage to the stria vascularis, anoxia to the neuroepithelium of the cochlea and the vestibular system. And when the stria vascularis, the capillaries of stria vascularis are damaged, they lead to increased permeability of substances through that, and that will lead to increased production of endolymph. So the second theory states about the increased production part of the disease. Endolymph is excessively produced, and that is the cause for Meniere's disease. So these are the two main theories, and there are various other coincidences that have been observed that could be related to the pathophysiology of Meniere's disease. One of them is allergy. Why allergy was thought to be related to Meniere's diseases? At least half of the patients of Meniere's disease have a concomitant inhalational allergy or a food allergy. So it's possible that Meniere's disease is multifactorial, and the common final result of all the various pathophysiological reasons, distension of the endolymphatic system, which is causing the symptoms of Meniere's disease. So allergy was observed in at least half of the patients of Meniere's disease. Next, it's also possible that sodium and water retention in the body could lead to endolymphatic hydrops, because in those patients it was observed that they have excessive amounts of retained sodium. Excessively retained sodium and water. Another possible cause is autoimmune etiology. Autoimmunity was suspected because certain HLA complexes such as HLA-B8 and DR3 were usually found associated with Meniere's disease, and maybe the inflammation is immunologically induced. That is an idea. Another possible finding is maybe there is some viral etiology. Causative viruses are cytomegalovirus or varicella zoster virus and herpes simplex viruses. Herpes simplex virus, varicella zoster virus and cytomegalovirus. These viruses are implicated in causing Meniere's disease, but it is not certain. Another observation is hormonal imbalance, and the hormone that is usually involved is the thyroid hormone, because in patients of hypothyroidism, Meniere's disease was observed. In about 3% cases of Meniere's disease, hypothyroidism was also present. Not just that, treating hypothyroidism improved Meniere's disease. Now that gave us an idea that maybe Meniere's disease and hypothyroidism are related. Not just they coexist, treating one is leading to the resolution of the other. Treating hypothyroidism is leading to resolution of Meniere's disease. So these are the various causative factors that have been implicated, but as I said, it is not exactly pointed out, and it is possible that various reasons are responsible in various people. Not everybody has the same etiology. Let us now study about the pathology of Meniere's disease. We have already understood the pathology briefly, and let us now look at it in more detail. So as we already know, the main pathology is distension of the endolymphatic system. Now why is it distending? That also we have tried to understand based on two theories, either excess production or defective adsorption. Let us see some of the changes that happen sequentially for distension of the endolymphatic system to occur. Distension of endolymphatic system. There is a perisaccular ischemia and fibrosis, and this ischemia and fibrosis leads to inadequate absorption of the endolymph by the endolymphatic sac. As I have told, this has been observed while performing endolymphatic surgery also, that the sac is ischemed and fibrosed. There is ischemia and fibrosis of the endolymphatic sac, and this leads to poor reabsorption of the endolymphatic fluid, poor reabsorption. And now the over-accumulated endolymph will expand in its chamber, but the space is limited. So it expands at the expense of the perilymphatic space. The endolymph is accumulating and expanding. So there is over accumulation of endolymph, and this expanded area is encroaching into the perilymphatic space. This encroaches into perilymphatic space. Where is the perilymph present? In the scala vestibuli and scala tympani. So this endolymph is encroaching into the perilymphatic space, and so there is distortion of the membranous labyrinth. There is distortion of various chambers and alteration in the size of endolymphatic duct and sac, along with the reduction in the tubular specializations of the lining of these structures is observed. There is alteration in the size. Endolymph is expanding, and the other structures where perilymph is present, they are becoming smaller and smaller, as you can see in the picture here. The endolymph is pushing the Reissner's membrane above and above. So there is alteration in the size of endolymphatic duct and sac. Now these changes, the endolymphatic changes, hydrops changes, are mainly present in the cochlea and saccule, that is the pars inferior part of membranous labyrinth. The changes are most conspicuous in the pars inferior, that is cochlea and saccule, and they are less or minimal in pars superior, that is the utricle as well as the semicircular canals. And the basilar membrane is getting distended into the scala tympani. The dilatation of the cochlear duct or the scala media is such that sometimes it completely fills the scala vestibuli, and there is marked bulging of Reissner's membrane, and even after that the cochlear duct is continuing to expand, so much so that the Reissner's membrane now herniates through the apex, that is at the helicotrema, into the scala tympani. You know that the scala vestibuli and scala tympani become continuous with each other at the apex of the cochlea, at the helicotrema. Helicotrema is the junction where these two fluids are meeting. These two chambers are becoming continuous, the scala vestibuli and scala tympani. So the Reissner's membrane, after it bulges and bulges, finally herniates into the scala tympani. The bulging Reissner's membrane finally herniates through the helicotrema into scala tympani. Saccule also gets distended. This is about the thing that is happening in the scala media. Along with cochlea, I told you, saccule is also a part of this disease process that is majorly involved. So saccular distension will distort the utricle and semicircular canals, plus this distended saccule now comes into contact with the stapes foot plate. And this is responsible for the Henneberg sign that the patient experiences. What is Henneberg sign? Okay, before that, the saccular distension affects, it distorts the utricle, semicircular canals, and also most importantly, the stapes foot plate. False positive fistula test is called as Henneberg sign. That is, fistula test is positive in the absence of fistula. That is called as Henneberg sign. Henneberg sign is a false positive fistula test. This is seen in two conditions. One is in congenital syphilis and second in Meniere's disease. The over-distended saccule comes in contact with stapes foot plate and gives a false positive fistula test, which is called as Henneberg sign. And next, even after this disease process continues and the Reisner's membrane continues to bulge, and at one point the membrane ruptures and gives in. And this rupture can happen anywhere in the inner ear. And once the Reisner's membrane ruptures, there is leakage of the endolymph into the perilymph. I told you endolymph composition is similar to that of intracellular fluid, and perilymph composition is similar to that of extracellular fluid. So endolymph is rich in potassium. And after the membrane is ruptured, after the rupture of Reisner's membrane, due to the increasing pressure from scala media, what happens is there is intermixing of endolymph and perilymph. Leakage of endolymph into perilymph occurs because it was the Reisner's membrane that was separating the endolymph and perilymph. And now they intermix. And endolymph is potassium rich. When this high concentration of potassium enters into the perilymph, it depolarizes the neurons and inactivates the vestibular as well as auditory neurons. And this is the core mechanism as to what is leading to vertigo, deafness and nystagmus. What happens when this potassium-rich fluid enters the perilymph? It causes depolarization of neurons. Potassium-rich endolymph causes depolarization of both auditory as well as vestibular neurons. And this is responsible for the clinical features such as vertigo, hearing loss, and nystagmus also. Then after some time the membrane will slowly heal, and that is when resolution of symptoms will occur. The patient experiences a symptom-free period when the membrane is healed. But the basic etiology is still not addressed. So again fluid begins to accumulate in the endolymphatic structure and it pushes the Reisner's membrane, and after some time the pressure becomes so much so that it breaks the Reisner's membrane again. And again there is repetition of this entire process, mixing up of perilymph and endolymph and causing depolarization and inactivation of vestibular and cochlear neurons. Again the membrane heals, again the pressure builds up and this process continues. But you have to understand that every time the membrane is healing and rupturing, it is becoming weaker and weaker and weaker, and finally a stage comes when it cannot heal anymore. It is permanently damaged and destroyed. That is when the symptoms of Meniere's disease do not subside by themselves. There is no relief period and the vertigo becomes very, very severe and the hearing loss becomes profound. All this is because of the repeated rupture of membrane and potassium exposure, leading to chronic deterioration in the function of inner ear. Membrane heals and leads to resolution of symptoms. Then the entire story repeats. Everything repeats and again there is rupture, again there is leakage, followed by healing. After many such episodes, there is chronic deterioration of the inner ear. This is about the pathophysiology of Meniere's disease. What exactly is happening and leading to those clinical features. Let us now study about the clinical features in detail. Before we understand the signs and symptoms, it's usually found in the age group of 35 to 60 years. And males are affected more than females. And the disease is usually unilateral, but it later progresses to become bilateral. Initially, one ear is affected, and after a few years, both the ears begin to get affected. And there are 4 cardinal symptoms of Meniere's disease, and they are: the first one is episodic vertigo, second is fluctuating type of hearing loss, and then tinnitus, and finally a sense of fullness that is present in the ear. Okay, let us understand about all these symptoms a little more in detail. Episodic vertigo is the first and most important symptom I can say. The vertigo attacks in the patient come in clusters and there is usually no warning that is present. So, as you all know, in vertigo, there is a sudden sensation of rotation. So, either the patient feels he is rotating and the environment is constant, or he is standing still and the entire environment around him is spinning and rotating. That is usually the complaint given by vertigo patients. An episode of vertigo could actually be very petrifying for the patient, because they usually have a feeling that they are about to lose balance and fall. And these patients present with the complaint of vertigo that is most bothersome to the patient, and they are actually scared. After an episode of vertigo, usually for many days later, at least for a week or 10 days later, the patient is very alarmed at going outside the house and also traveling alone by himself. So that is an episode of vertigo, and these patients of Meniere's disease have clusters of such episodes. They have an attack, and for 2 or 3 days they keep on getting episodes of vertigo, and then they are symptom free for a few weeks to months, and again they have episodes of vertigo that last for 3 to 4 days. Again there are on and off attacks, and finally they are again symptom free for a period of time. Now, during this episode of vertigo, sometimes there could also be presence of vomitings and nausea. And also, these patients exhibit some amount of ataxia and nystagmus also. So, it becomes essential that we rule out a neurological problem. Because there is nausea and vomiting, of course, in neurological cases, there is projectile vomitings. But sometimes the patients cannot give you a proper history whether it is a projectile vomiting or a non-projectile vomiting. So, symptoms that are leading us towards, that are making you suspicious of a neurological disease are, there is nausea and vomiting, plus there is ataxia and this loss of balance, spinning sensation by the patient. So, sometimes we suspect a cerebellar problem actually. So, it's essential that we rule out some other neurological issue and come to the diagnosis of Meniere's disease. So, what we observe in episodic vertigo are, there is this classical spinning sensation experienced by the patient. Either he is rotating or the environment around him is rotating, and not just rotation, sometimes they have a swinging feeling as if they are moving to and fro, or sometimes they are moving up and down. All these bizarre experiences are felt by the patient. and vertigo occurs in clusters, followed by a symptom-free period. Along with vertigo, it is accompanied by nausea and vomiting, ataxia and nystagmus. Usually there is no warning before an episode of vertigo occurs, but in some patients, as I told you, tinnitus is also one of the symptoms of Meniere's disease. They experience a change in the type of tinnitus before an attack of vertigo, and that acts as a warning sign. And the sense of fullness in the ears is also increased before an attack. Another clinical symptom experienced by the patient is Tullio phenomenon. What is Tullio phenomenon? It is vertigo experienced when exposed to loud sounds or noises. Vertigo when exposed to loud sounds or noises. That is Tullio phenomenon, and that's usually seen in Meniere's disease. Now, why does vertigo occur on exposure to loud noises? It is because with the loud noise, the stapes foot plate vibrates vigorously, and you know that the saccule is in close contact with the stapes foot plate, and this over distended saccule comes all the more in close contact to the foot plate of stapes, and it gets irritated or stimulated, leading to vertigo. So that is Tullio phenomenon. Not just in Meniere's disease, Tullio phenomenon is also observed when there are three functional windows. Three functional windows in the sense, normally we have two functional windows, the oval window and the round window. Oval window is where the foot plate of stapes is closing it, and round window is also called as the secondary tympanic membrane. Apart from these two, if there is another third functional window, how can a third functional window occur? Suppose in the horizontal semicircular canal, if there is some dehiscence, that acts as a third window. And when there are three functional windows also, this Tullio phenomenon can be observed. The next clinical feature that is observed is hearing loss. Hearing loss usually accompanies vertigo. When the patient is having an attack of vertigo, that time only he experiences hearing loss also. And as the vertigo subsides, even the hearing improves, and there is a period of remission for hearing loss. And again, when there is an attack of vertigo, again hearing loss occurs. So it is a fluctuating type of hearing loss. Fluctuating type of hearing loss. Now please do not get confused with the fluctuating nature of pure tone audiometry in malingerers or non-organic hearing loss. There, because the patient is trying to cheat, immediately back to back if you perform two audiometries also, there will be difference, because he has to remember at what point he said I am not able to hear and exactly reproduce that in the next test also, which is not possible. So in malingerers, immediately if we perform also, suppose say today I perform an audiometry and again tomorrow I perform an audiometry, or in the same day, morning and evening if I perform audiometries, there will be difference in the hearing loss. That is fluctuating type of pure tone audiometry results. This is fluctuating type of hearing loss. The hearing loss itself is fluctuating. So these two are different things. Kindly do not get confused when this term is put in the MCQ or a case question. Okay. So there is a fluctuating type of hearing loss in Meniere's disease, and this is a characteristic feature actually of Meniere's disease. And what type of hearing loss is it? It is a sensorineural type of hearing loss, and in sensorineural also it is cochlear type of hearing loss. In sensorineural, we have cochlear as well as retrocochlear type of hearing loss, and this is a cochlear type of hearing loss. And along with hearing loss, there are certain other complaints by the patients such as distortion of sound. Distortion of sound, also called as diplacusis. Does this remind you of diplopia in ophthalmology? Now, why distortion of sound occurs is because a particular sound may appear normal in one ear and in another ear it could appear high-pitched, and this disturbance will lead to distortion of sound, also called as diplacusis. And even when such patient is hearing music, it's all discordant and disturbed, which could be bothersome for the patient. And also, there is intolerance to loud sounds. Why is there intolerance to loud sounds? Because in cochlear type of hearing loss, there is a symptom called as recruitment. What is recruitment? Initially, the patient cannot hear low intensity sounds, and suddenly after a point, the sound becomes abnormally loud. And when it becomes abnormally loud, it becomes louder than the normal ear also. The diseased ear hears a sound louder than the normal ear also. And definitely when it is so loud, the patient cannot tolerate such huge intensity sound. That is recruitment phenomenon, which is not just specific to Meniere's disease. It is observed in all cases of cochlear type of hearing loss. So because of recruitment, this occurs. Due to recruitment phenomenon. Now the bad part about recruitment phenomenon is these candidates are not very good for hearing aids, because when we prescribe hearing aids and the sound gets amplified in the affected ear, suddenly it becomes very loud for them and they cannot tolerate that loud sound. So this is the consequence of recruitment phenomenon. The next symptom after hearing loss is tinnitus. Tinnitus is a ringing sensation that is experienced in the ear of the patient. And this tinnitus could be of various different type of sounds. The tinnitus in Meniere's disease is usually of a roaring type. There is a roaring type of tinnitus. Mostly it is a roaring type, but sometimes even a hissing type of tinnitus is also observed, experienced by a few patients. And this low-pitched roaring type of tinnitus gets aggravated during an acute attack, that is during an attack of vertigo. And it subsides during the period of remission. As I have told you, in vertigo also, a change in the type and pitch of tinnitus, it could be a warning sign that an acute episode of vertigo is about to occur. The last and final clinical feature is a sense of fullness in the ear. Sense of fullness or pressure in the ear. Why do patients experience this? Because there is distension of the endolymphatic sac, and that gives the sense of fullness. Fullness in the inner ear, which the patient cannot do anything about. And this symptom is also fluctuant. It is present during an acute attack and sometimes it subsides. So these are the 5 cardinal features of Meniere's disease. First is vertigo, and a variant of that is Tullio's phenomenon. Next is fluctuating type of hearing loss. Then we have tinnitus, roaring type, and also a sense of fullness in the ears. These are the 4 cardinal symptoms or features of Meniere's disease. Now, along with these features, there has been observed that there is some association with the emotional status of the patient also. So, earlier it was thought that the emotional upset of the patient is the cause for all these symptoms. But now it is thought to be vice versa also. Maybe all these symptoms and clinical features make the patient emotionally fragile. As I told you earlier also, vertigo could be very, very disturbing and scary to the patient. Not just vertigo, he's also experiencing a sense of fullness in the ears, not able to hear properly, plus there is this roaring sound of tinnitus. All these could make the patient really affected. Now, upon examination, because Menieres is a disease of the inner ear, there are hardly any findings. If we do an otoscope, the external ear is normal, the tympanic membrane is also normal. So, otoscopy findings are normal. On examination, otoscopy is normal. Now, if you see the patient during an acute attack, sometimes patients immediately come while the attack is still there, and that time you could see nystagmus during the attack. So, nystagmus is one feature that could be observed, and definitely when the patient comes for ENT evaluation, that too with a complaint of hearing loss, we do perform tuning fork tests. And we find the features of sensorineural type of hearing loss. What are the features of sensorineural type of hearing loss? Menieres is positive. Now, Menieres is positive in a normal person as well as in a person with sensorineural type of hearing loss. Weber is lateralized towards the better ear. Weber is lateralized to better ear. And absolute bone conduction test is reduced on the affected site. Absolute bone conduction test, it is reduced on affected site. So these are all features of sensorineural type of hearing loss. Upon examination, it's very, very minimal because it's an inner ear disease. The changes cannot be much appreciated. Now let us see how we proceed with the diagnosis of this condition. Let us study about the management of Meniere's disease in the next video, investigations and the treatment part. Thank you very much.